classes and I think goes to what, 3, 4 of them, but is a resource to all 10 or whatever. So she is all over the place with primary care. She went to pharmacy school at UNC and did residencies at VCU and then Ohio State, specializing in AM care, but has a special love for cardiology, and her ambulatory care residency kind of subspecialized in that. So she's going to be talking to us for the next 2 weeks about diabetes management, specifically related to cardiology and heart failure.
All right. Well, thank you guys for coming. So I've heard a lot of buzz before we got started that you guys are excited for this, so I'm glad you're excited. I will preface and say a lot of the medications we're going to go over are not on our formulary. So it might not be something that you're deciding on for the patient like to initiate here, but it's really helpful when we're thinking, what do we put them back on when they go home, or what could we recommend the primary care consider, or what do we want to consider in follow-up, those type of things. All right. So you guys know it's a problem. So we're having more and more patients diagnosed with diabetes, and with that comes more and more cardiovascular disease associated with diabetes, and this number isn't going anywhere anytime soon. So some of the statistics, we know that patients with diabetes have the same 7-year risk for an MI for patients with diabetes as those who've also had an MI but don't even have diabetes. So higher risk of myocardial infarction, higher risk of stroke, higher risk of heart failure, and then ultimately cardiovascular death. So these are the outcomes that we're going to be mainly focusing on and talking about how these medications either help or harm these outcomes. Okay, so we'll jump past that and talk about how we have data to say that with tighter glycemic control, we have improved microvascular outcomes, so retinopathy, nephropathy, and neuropathy. We have some meta-analysis data to suggest that intensive glycemic control does reduce the risk of cardiovascular events, but it's not to the same extent as our blood pressure studies or lipid management studies. So there's something else that's contributing to this elevated cardiovascular risk beyond just blood sugar. So in 2008, the FDA set new expectations for approval of all new diabetes medications, that they had to have cardiovascular outcomes for safety. And this was prompted by the controversy surrounding rosiglitazone in 2007. So rosiglitazone had been on the market. It had been a pretty good uptake based on, we'll talk about how it works, but it had a unique mechanism. It seemed to work really well, and it was another option to add for our patients with diabetes. But what we found is that with rosiglitazone, we saw in a meta-analysis there was an increased risk for MI in patients randomized or that were on rosiglitazone. Fortunately, no difference in cardiovascular death, but this was enough to warrant the FDA to place a black box warning on rosiglitazone that it might increase the person's risk of heart attack and angina. And so this was kind of the first time that one of the first times that it wasn't liver dysfunction and other things popping up. It was really cardiovascular safety that was at the forefront of their concerns. And so this black box warning stayed on until 2014 was when it was officially removed. But in 2009, we had the record study that kind of wanted to look at this again. So rosiglitazone versus placebo, it was an open label trial. And they had patients with diabetes that were on metformin or sulfonylurea monotherapy, and then they added rosiglitazone or the active control, which was the metformin sulfonylurea. And they saw that rosiglitazone was not inferior to the active control, so no difference. And there was no difference when we looked at cardiovascular death, stroke, or MI. We did see increase in heart failure admissions or death, and this was already widely known about rosiglitazone and its counterpart, pioglitazone or Actos. So we already knew that these agents increase the risk of heart failure. They're contraindicated in patients with heart failure. So the main point of this was to try to debunk that MI risk, and this is what led to the FDA feeling comfortable removing that black box warning. So technically rosiglitazone does not have that anymore, but you've probably noticed we don't have very many people taking this medication. So the MET class in general, they work by activating a transcription factor, PPR gamma, and they basically are insulin sensitizers. So they're great at increasing our body's utilization of insulin that we make. They're not associated with hypoglycemia, which is nice. They have a durable glycemic control, so over time we don't expect these to stop working as well. And they can decrease A1C by a pretty good amount, so 1 to 1.5 percentage points. But they come with a lot of caveats, so weight gain, fluid retention, bone fractures, heart failure, and a slight increase in LDL with rosiglitazone. So you would think that if I'm telling you this about the class, the whole class is kind of a wash in terms of cardiovascular safety. And when it comes to heart failure, you're correct. There's no patient with heart failure that we're going to use these medications. But when it comes to other types of cardiovascular disease, there might be patients that we want to use these in. So there were 2 different studies that I want to highlight quickly. So the ProActive study, it was pioglitazone versus placebo, and they had type 2 diabetes and extensive macrovascular disease. They saw that pioglitazone reduced the composite all-cause mortality, non-fatal MI, and stroke. Notably, this was one of the secondary outcomes of the study. So this did not go on to add any extra labeling with pioglitazone or anything along the lines of some of the other medications we're going to talk about that were specifically designed for this composite outcome. But it does show us that maybe there's some benefit or a difference with pioglitazone versus rosiglitazone in terms of cardiovascular safety. The IRIS study was a little bit different. So this study was in patients who did not have diabetes. They had had a recent stroke or TIA with some insulin resistance, and they found that patients, their primary endpoint, so patients in the pioglitazone arm had a decrease in fatal or non-fatal stroke or MI, and this was statistically significant. So with a number needed to treat of 36. So this data is really exciting, but it's a very niche thing, and I don't feel like we've really seen this come out so much in practice, because again, these were not diabetic patients. And with all the risks that are still associated with this class of medications, I don't think this is enough to completely change things. I will say though, in the outpatient world, this is one of our generic medications. So if I have a patient who can't afford anything and they don't have heart failure or any other issues with edema or anything like that, then this could be on our list of options for their medication. So it would not be impossible for someone to come in and be taking one of these medications. So then it made me think, okay, why rosiglitazone versus pioglitazone? There has to be maybe something going on between the two. And there's some thoughts that pioglitazone activates 2 different, so PPR gamma and partial activation of PPR alpha, and they're thinking that that gives it some more favorable effects on like fat distribution, glucose, lipid, and protein metabolism. But again, these are mostly in animal studies, and so they're trying to tease out the difference between the 2, but we at least have some data that pioglitazone looks a little bit better. The next class, that's an older class that we still use quite a bit, are the sulfonylureas. So the cardiovascular safety concerns with these guys first began way back in the 1960s with tolbutamide. And there was a study that found an increased risk of all-cause mortality and cardiovascular mortality with this medication. This medication is not on the market. We have 3 currently on the market that we use, so glyburide, glipizide, and glimepiride, so our 3 Gs. Big things is they are renally adjusted, so glipizide is our preferred of the 3 because it doesn't have active metabolites, and so in a shorter half-life, so it's the one we typically go to in like our elderly patients if we have to use one and they have impaired renal function, because again, we don't have those active metabolites sticking around the whole time. They do run the risk of hypoglycemia because they are causing the pancreas to secrete insulin, whether or not a patient has an adequate amount of glucose in their blood. The pancreas gives off the insulin, so they do set up a picture of hypoglycemia, so we don't use these with things like mealtime insulin, and they can cause weight gain as well. This isn't the fluid edema that we looked at with the other class of medications, but weight gain nonetheless, so not favorable in our diabetic patients. There is mixed information about the sulfonylurea. So every year, the American Diabetes Association does their standards of medical care in diabetes, and now it's really nice. They've started including a chart that talks about cardiovascular safety, plus, minus for heart failure, or other cardiovascular outcomes and other side effects, costs. Try to pull all those things together for us. And in their chart, they put sulfonylureas as neutral for cardiovascular risk. But when we look at the American Association of Clinical Endocrinologists guidelines, they put it as a potential risk. And so it looks like they're taking their data more from some of these other meta-analyses we have out there. And so we don't have a perfect study that says sulfonylureas are terrible. You can find, if you want to support that they're not bad, then you could find that study, but I will say that most of the data, I think, is pushing us towards the fact that they do have a cardiovascular risk. So this one I highlighted here in 2017 was a large systematic review and meta-analysis, and they found increased risk of all-cause mortality and cardiovascular-related mortality, higher risk of MIs when they compared sulfonylureas to some of our other medications, some of our newer ones, and higher risk of stroke compared to some of our newer ones, and TZDs and insulins. So those are kind of the old classes of medications. We will talk about metformin, but it's not really in this category because it's our one kind of beacon of hope from our old medications. When we talk about some of our new ones, the first class I wanted to review were the DPP-4 inhibitors, so dipeptidyl peptidase 4 inhibitors. So they're working on inhibiting the activity of DPP-4, which is an enzyme that is responsible for breaking down our incretin hormones, GLP-1 and GIP. So these medications enhance that incretin effect, and they promote glucose stimulated insulin secretion, so glucose-dependent insulin secretion from the pancreas. Why that's nice is there's no then risk of hypoglycemia, or not the same risk as we see with our sulfonylurea, so that part is good. And they have their effects. I tell people they kind of lie in wait, and then they work. When the pancreas is trying to work and give off more insulin in response to food, these kind of help amplify that response. So you can take it one time a day or even one time a week, one time a day, and it's just working for them. They are renally adjusted with the exception of linagliptin, so that is the one we currently have on formulary. It's nice because it's one dose, don't have to dose adjust it for renal impairment. They do have some unusual side effects listed there, so there's some question about acute pancreatitis, and this crosses over to our other class of medications like our GLP-1 agonist as well. So if you read the package insert for these, they don't recommend them in a patient with history of pancreatitis unless you have clearly identified what caused it and you've ruled that out as a risk of recurrence. And they can lower A1C by 0.7 to 1%. So not our heavy hitters when it comes to A1C lowering. They're nice because they're an oral option for our patients, but they don't have some of the other benefits that we'll talk about with our medications, the GLP-1 agonists. So they don't mess with gastric emptying or produce any sort of satiety effect in our patients. Okay, and then the trials for these that I wanted to quickly run through to compare, the Saber-Timi, the Examine, and the TICO. So again, it's after 2008. These drugs were coming to market. They have to do cardiovascular safety. So for saxagliptin versus placebo, large trial, these patients had a history of cardiovascular disease or they had multiple risk factors, and they did find that the primary endpoint, which for all of these, the primary composite was cardiovascular death, MI, and ischemic stroke or non-fatal stroke. So those we can say across the board, the good thing is none of these saw an increased risk. They were on non-inferior to placebo, which is ultimately what the FDA wanted to see. But what did come out of these was another interesting finding about this increased risk of hospitalizations for heart failure that we saw with saxagliptin. And so this was statistically significant. Other studies have also gone on to look at that. So alogliptin in patients with a recent MI suggested an increased risk of heart failure. So this was not statistically significant, but this was enough for the FDA to put a warning on both of these medications about the potential increased risk of heart failure. We look at sitagliptin versus placebo, and these patients did have cardiovascular disease, and they saw no difference in hospitalization for heart failure. So if we kind of compare the three, we have our one that we don't want, the one that we're not sure about, and then the one that seems to be okay in terms of our cardiovascular safety. More recently, so this was published in November, the Carmelina study was our linagliptin study, so something we were waiting on because that's the one we use, but it was one of the newer medications in this class. Over 6,000 patients, they had diabetes and high risk for cardiovascular events, so this meant they had albuminuria, previous macrovascular disease, and or impaired renal function. They were randomized to linagliptin versus placebo, and then the primary endpoint was what we had talked about before. And they also included a secondary endpoint of a composite renal endpoint, because again, this is one medicine in this class that kind of owned the market when it came to our patients with renal impairment. they found that linagliptin was non-inferior for the primary and secondary outcomes. So again, no difference in the cardiovascular safety here, and then no difference in the composite renal outcomes. So it didn't hurt things, but no benefit really seen. But they also did not see an increased risk of heart failure hospitalizations for linagliptin. So I think it's important to note for this study in particular, so a quarter of the patients had heart failure at baseline, so they did include those patients, so it wasn't just new onset heart failure. And so this kind of throws out the idea that it's probably not a class effect for these medications, or we no longer think it is, now that we have kind of an even split between the class of ones that might be harmful and beneficial. Or not beneficial, but neutral. So, brief review. So, our two DPP-4 inhibitors that increase the risk of heart failure or hospitalization for heart failure. So, we have two options. So, does anyone think it's A? Anyone think it's B? C? Yeah. C. I agree with you. So C is our culprit. Those are the two that carry that warning from the FDA. Okay. So this is kind of another quick case that we'll do. So we have a patient, they come in, they have heart failure, they have diabetes, hypertension, and atrial fibrillation. They come in complaining they've gained 20 pounds in 2 weeks. So for you guys managing their heart failure, you're probably thinking, oh gosh, what's going on? Maybe they're fluid up, maybe we need to adjust their diuretics. Their A1C 7.7%, you can see their medications listed here. So if you look at their medications, especially as a pharmacist, we look at it and first do no harm. Like what's standing out to me as something that needs to go away or that could be contributing to this? So is there anything that they're taking that you're worried about?
Pioglitazone.
Yeah, exactly. So they're on pioglitazone. So if we had to do something today, I would recommend the first thing we would do is get rid of the pioglitazone. They shouldn't have been on it. Fortunately, I don't feel like we see this very often, but if you ever did, this would be an easy, get that off, we don't need that anymore. And then you can continue managing the other acute complaints that they're having today. Okay. So with, as I mentioned, with the ADA, they're trying to do a better job of, putting diabetes and cardiovascular disease in the same bucket. We know that they're intimately linked, but for a long time, we've managed them very separately. We're control your blood sugar, and hopefully by doing that, we decrease your cardiovascular risk. But now we're thinking, okay, maybe it's not just what your blood sugar is, but it's how we get there. What medicines do we use to achieve that blood sugar? So they still recommend metformin as monotherapy for our patients, but then they talk about if you had to add dual therapy, there are some options for patients with cardiovascular disease that you might consider, and these we'll go through. So liraglutide or Victoza, empagliflozin or Jardiance, or canagliflozin or Invokana. Those are the three listed there. And then if they don't have cardiovascular disease, it's kind of a little bit more wide open based on the factors we've already been discussing. So metformin, I mentioned it's kind of our oldie but goodie that we have for diabetes medications. So it was approved for diabetes in 1994, so it's been around a long time. I mean, tolerability issues are mainly diarrhea. We counsel patients take them with food, but we do see a substantial A1C lowering, so they can lower A1C by, it can lower A1C by 1 to 2 percentage points. It comes in a lot of combinations with other medications, and so it is still first line for diabetes. And for a long time, it was the only diabetic medication we had that looked to have any sort of favorable cardiovascular outcomes. And this was not based on one of these beautiful studies we have now. This was older data from the UK PDS group. So they saw in a subgroup of patients that were randomized metformin to conventional therapy, which was dietary restrictions, so metformin versus not. They saw over a 30% reduction in the risk of non-fatal MI. So you could say, there's a lot of limitations when we first look at that study. They were randomized to no treatment, which is not what we do anymore. And it was a very kind of small sample size, but a very significant finding. What they did was 10 years later, they did a study that looked at the patients that were 10 years ago put in the metformin arm and compared them to the patients that weren't in the metformin arm. These patients could now be on anything. So this was just at the time they were on that. They look back and those patients still had a 33% reduction in the risk of MI compared to the ones that weren't treated with metformin way back when. So while we don't exactly understand why metformin does this, this kind of legacy effect has, I think, even more solidified the fact that metformin is safe and potentially has a benefit for our patients with cardiovascular disease. Typically on inpatient, if they're coming in acute decompensated heart failure, we're stopping metformin, but thinking about how important it is to resume this to make sure that for that good transitions of care when they get home, when they're managing their diabetes and their other comorbid conditions, they have this back on the regimen. Because I have seen patients, and it's come from primary care too, where it was stopped because of heart failure, and I think the thought was, oh, because they have heart failure, they can't take it, and that is not the point that we want to make sure we make.
What is the creatinine clearance you look at
Yes.
for holding metformin?
Yes, so you're right. So it used to be based on a serum creatinine, and now it's based on EGFR. And so if it is over 45, you can continue as business as usual. If it's between 30 and 45 and they're already on metformin, you can consider decreasing the dose, or you can continue it and just watch and wait. But they do not recommend starting it in people in that 30 to 45 range. If they're under 30, we don't do it. So it's nice, we have a little bit more leeway to continue metformin longer in these patients. All right, and then the ones that you probably hear more about, there's more and more coming out about them, so our SGLT2 inhibitors. The SGLT2 receptor is located in segment 1 of the proximal tubule, so it is responsible for 90% of glucose reuptake. And so even though our body shouldn't want to do this, when we have elevated blood glucose, our body will think we need to continue to reabsorb that glucose because, again, our muscles are starving. They're not getting the glucose that they so desperately need because that insulin resistance or some other issue having the insulin work appropriately to get glucose where it needs to go. So our bodies are reabsorbing this glucose, therefore increasing our blood glucose even higher. These medications block that to allow for glucose to come out in the urine. With that comes water, with that diuresis type effect. There are now 4 in the class, so as of December of last year, ertugliflozin is the new one added. Right now there's not a whole lot out there about that one, honestly. We have drug representatives that come to primary care, different offices depending, and I haven't seen anyone for this medication, nor have I really read any big data coming out for it yet. Because it's after 2008, it will have to do its fair share of the work in terms of coming out with a study, but it's not there yet. The main 3 you see are canagliflozin or Invokana, dapagliflozin or Farxiga, and empagliflozin or Jardiance. You can see the doses there. They are renally dose adjusted, and it's less of a safety concern, more of an efficacy concern. So if we are getting worse and worse renal function, the thought is that these medications just can't do their mechanism of action the way that they need to. And we'll talk about some of the potential renal benefits that we're starting to see in some of these studies. Because of their mechanism, we do have, potential for volume depletion or hypotension, so we worry about that in older patients, or polyuria, genitourinary infections. We can even see a slight increase in their LDL, which is interesting when we think about all the positive outcomes we'll talk about shortly. Transient increase in serum creatinine, and then there have been some case reports, and even in some of our studies, higher rates of DKA in our patients treated with these medications, and it's a euglycemic DKA. It's a very unique mechanism, but fortunately it's not very common. In one of the studies we'll talk about, it's like 0.3% of patients versus 0.1% in the placebo arm.
And what about canagliflozin and toe amputation?
Yes, so that is kind of the new thing that when we look at the data is more specific to that one in particular, but we'll definitely talk about it because that's what people are going to ask you about. If you say, hey, I want you to take Invokana, they're going to maybe have heard of this and want to talk about it.
Could you also address
Yes.
metformin and lactic acidosis with dye?
Yes, with dye. So
I can tag.
I was about to say, it's more of a better safe than sorry at that point. Just if we're going to impact their renal function and increase the body's exposure to metformin, we therefore increasing that risk of lactic acidosis. So we hold it surrounding that to prevent that from happening.
So we've always held it. There's actually radiology guidelines that I learned about a few years ago that say that if the renal function is fine, we don't really have to hold it. If someone already, if they're borderline or in that 30 to 45 range, like Marie's talking about, which is probably a chunk of our heart failure patients, then it's reasonable to hold it because, like Marie said, better safe than sorry. It's not going to do the patient any harm to, miss for a few days. But if it's somebody who's like going for like an elective cath or whatever, like, and their renal function's fine, I don't really care. So, and the same goes for like holding it for 48 hours after and all that. Like if they're fine, we get all these like pharmacy communications, like going for cath, hold metformin for 48 hours. I'm thinking, that means-
Yeah,
I
it
know.
is part of the pre-checked order set.
I know. Well, it's not pre-checked. It might be on yours.
It is on,
It's
okay.
not on CAD.
Yeah, and we don't even give dye. We don't even give dye.
And it's
That's the
also,
best part.
it's also part of our discharge box, metformin. You know, hold it,
Interesting.
yeah.
Well, Jason added that.
I mean, it's fine if you want to. I think it's just like,
Yeah, I think as long as we're, you know, it's in there that they're holding it this time and then it's gonna be resumed at discharge, then I think it's perfectly fine. But fortunately, it's not insulin or something they acutely need to still have on board, so if we had to skip a couple days, it's not gonna impact their blood sugar control enough to really mess things up. Good questions, though. Right, so the big IMPEREG study, so this was, of these medications, they had to do these cardiovascular outcome studies, and the first one that got published was the IMPEREG study. It was not the first SGLT2 to market, so canagliflozin was approved first, but this study came out first. So this patient population had diabetes with established cardiovascular disease, so high-risk patients. They were randomized to either 10 milligrams of empagliflozin, 25 milligrams, or placebo. And again, they're looking at this composite outcome: cardiovascular death, non-fatal injury, non-fatal stroke. They had established cardiovascular disease. A1C was about 8%, and they had diabetes. Most of them had diabetes over 10 years. What's interesting is we don't know what percent had heart failure at baseline. They didn't use systematically collected like biomarkers or echo data to really categorize that. They said, you know, there were few investigator-reported heart failure patients at baseline, but when we look at what these patients were taking and how sick they were, we feel like there probably was a substantial amount of patients that had heart failure, but this wasn't put here because, again, at the time of this study, we didn't really know that that's something they wanted to look at. It was just, again, a safety thing. So the exciting part was the primary outcomes. So the primary composite outcome was statistically significant. And so the first one is for non-inferiority. So that, again, that's what the FDA said they had to do. But then they had already pre-specified superiority, so they went on to prove that. And what's nice is that when we think of our composite outcomes, usually we find that they're driven by maybe a softer outcome like MI, not usually driven by death. So this one you can see that death from cardiovascular causes, non-fatal MI, non-fatal stroke, of those three, only the death from cardiovascular causes was a significant outcome. And it was so significant or so substantial that it drove that whole composite primary. And then they also saw this other finding that when you read their trial, it does not sound like they anticipated to see this decreased risk of hospitalizations for heart failure. When we look at the data, it's interesting too because we see that these curves diverge pretty quickly. And so the thought is that maybe this is more due to hemodynamic effects than we think of maybe some of our lipid studies. This is not what we see in some of our statin trials. This is usually a later divergent in the curves versus here within 6 months we're seeing a significant difference between the two arms of treatment. When we think about other things, so they had, with this class of medications, because of this diuresis, you can get a little bit of blood pressure lowering. So systolic blood pressure decrease, maybe like 4 millimeters of mercury. You can also get some weight loss, because again, we're getting rid of calories when we get rid of that sugar in the urine. But really, systolic blood pressure in this study was about 2 millimeters of mercury difference. So when we think about all the outcomes they saw, it doesn't sound like it's because their blood pressure was 2 millimeters of mercury lower, or that they lost a lot more weight. There's something else going on with this class of with this medication in particular. And so this was kind of a blockbuster study. So they saw the significant decrease. They saw this early onset of benefits, which again was not something we expected, but leads us to think it's probably more hemodynamic changes. And they think, again, this kind of blanket, oh, it's multidimensional. These medications are affecting cardiovascular health in multiple different ways that we will talk about. So this went on to give Jardiance or empagliflozin an FDA indication. So they have an indication in patients with diabetes and cardiovascular disease, this medication can decrease the risk of cardiovascular death. So this was the first time we had a diabetes medication that had anything on the label to do with cardiovascular disease, so very exciting. But when you read that label, I think what's interesting is it doesn't highlight the heart failure piece as much. But I think it's because this was a outcome that they were looking at for safety, but this was not their primary outcome. So they weren't able to get that labeling, but we know by looking at this data that it was quite substantial. We then had Canvas, so they had to do their turn. Their study was a little bit messier in my opinion. They had patients with diabetes who either had ASCVD or those who had risk factors and they were a little bit older. So nice because we had primary and secondary prevention patients. They were randomized, they had two different studies that they ended up putting together. So the Canvas study, which was originally going to be their cardiovascular study, and then the Canvas R study, which was this renal study they were doing. Well, when they wanted to get more data more quickly and get this out there, they combined the two with the approval of the FDA to be able to show these outcomes. But they put these two studies together, and then you get this overall sample size of over 10,000 patients. They were, the primary composite, when you looked at everyone, was the same as we had looked at before, but they were also looking at some renal outcomes, because again, they had this renal piece of the study that they wanted to look at. Majority of patients had cardiovascular disease. You can see that when it comes to their average A1C was very comparable to the InfraReg study, and the mean duration of diabetes was a little bit longer. So while less of these patients had cardiovascular disease, there is some argument that maybe they were a little bit sicker in terms of their diabetes. So for their primary outcome, so they did also see a statistically significant primary outcome. What's interesting here though is no piece of the composite alone was significant. So without putting these three outcomes together, we weren't seeing this benefit. But that was superior to placebo. Again, we see this dramatic decrease in hospitalizations for heart failure. So it looks like maybe this is a class effect. This is a benefit we keep seeing. And for those renal outcomes they had looked at, so less progression of albuminuria and then lower composite renal outcome. And so that was things like greater than 40% decrease in their EGFR, new end-stage renal disease, those type, renal death, those type of outcomes were as that composite. A hypothesis generating type composite, because you'll see we have other things in the works that are looking specifically at those outcomes. And then the thing that takes away, so not only can we argue that maybe the outcomes weren't as exciting as the InfraReg study, we also had this side effect that came, or this adverse event that came to light in this trial. So we saw similar rates of vaginourinary infections that we had seen and that we kind of knew was associated with this class, but we then saw this increased risk of amputation. And this was statistically significant. And so there's thoughts to this, right? Like, you know, they included patients with peripheral artery disease. They said that they saw more amputations in patients that had more risk factors for amputations, which makes sense. But it's not as if the groups were unbalanced between them and placebo. I've heard the argument that these patients were sicker, their diabetes was worse, so maybe this got brought to light. The InfraReg study collected this data, but didn't find a difference. It's buried in the supplemental, but it wasn't there. And so the FDA put a black box warning on this medication for the potential increased risk of amputations. And in Europe, they put it on the class. So every medicine in this class has this warning now. So very concerning for our patients because you're trying to get them on board with this medication and the benefits associated with it, but then they're worried about physically what is it going to do to them, because you can't always appreciate this risk of stroke, but you can definitely appreciate what it would be like to not have your left or below the knee amputation. So the authors say that they did see decreased risk in composite primary outcome, possible benefit with these renal outcomes, so positive, positive, but then this increased risk of amputation that led to this black box warning. The Observe 4D study that was done at UNC was a retrospective claims data. They looked at claims databases to try to see, okay, is this amputation thing really happening? And they compared canagliflozin's effects on hospitalization for heart failure and below knee, lower extremity amputations versus our other SGLT2 inhibitors. And at the time, this was the empagliflozin that we just talked about and the dapagliflozin or Farxiga that we're about to. And they said, compared to the other ones, there was no difference in either outcome. And then compared to our non-SGLT2 inhibitors, that canagliflozin had lower rates of hospitalizations for heart failure. So again, this class or this medication is having lower rates and no difference in below knee amputations. And this is real world data, but they really weren't able to tease out that canagliflozin was worse than the other guys, nor did the class itself have this dramatic increased risk. So it's trying to ease our minds when looking at these medications as options. We have other real world data of these medications as well. So we've seen lots and lots of studies looking at them that have continued to show this lower risk of hospitalizations for heart failure, and some of them even also showing this lower risk for cardiovascular mortality and MACE in specific patient populations like the CVD Real Nordic study. Less countries, but still a large patient population when they compare this class versus other medications. Now the last thing we'll touch on, I'm sorry, this one just came out in November, so it's still e-published ahead of print. It's the Declare TIMI study, so this is Farxiga's blockbuster. This one was slated to be the biggest, and it by far is, 17,000 patients. So they could have cardiovascular disease with diabetes or just risk factors. Those risk factors were for men age over 55, women over 60, and they could either have hypertension or dyslipidemia or tobacco use. Oh, I'm sorry, I didn't hit this button. There we go. Okay, so they had two primary outcomes because they saw what happened with the IMPREG study and they said, oh, we want a piece of that. And so they had their composite one that the FDA said they had to do, and then they also did one for cardiovascular death and hospitalizations for heart failure as like a second primary. They also had secondary outcomes looking at renal outcomes because again, they're taken from Canvas and saying, oh, we want the renal stuff too. And you can see here that less than half of patients actually had cardiovascular disease, so much more mixed population. They do tell us that 10% of these patients had heart failure at baseline, so they learned from their friends as well that they needed to report this. It was helpful to have this information. And they saw that there was a significant decrease in the one of the primary outcomes. So that one that had cardiovascular death and hospitalizations for heart failure was significantly lower in the Farxiga or dapagliflozin group. MACE, or the other primary outcome that we've been seeing over and over again, was not different, so it was safe, but no better. They saw better composite renal outcomes and hospitalizations for heart failure. So again, we're seeing this same trend come up. Some of the outcome, there was no difference in risk of amputation between placebo and this one. There were actually more serious adverse effects in the placebo arm, and but more patients in the dapagliflozin ended up discontinuing therapy due to an adverse effect. So ultimately, these authors are saying in patients who either had ASCVD or at high risk for it, dapagliflozin was non-inferior, so safe for the major adverse cardiovascular endpoints. They did have lower rates of hospitalizations for heart failure and cardiovascular death, but I like that they do highlight in their study that this was completely driven by the lower rate of hospitalization for heart failure. So there was no difference in cardiovascular death. It was all because of this hospitalization for heart failure. And there's this possible benefit seen with the renal outcomes. So briefly, when we think about why this probably is, there's a lot of different theories out there. So there's thoughts that this increased fluid loss, decreased intravascular volumes, decreased blood pressure, we're going to lessen the stress on the heart, the preload, the afterload, and might help with oxygen supply to the heart. There's also this thought that maybe there's a benefit on vascular function. That one is not as well teased out in terms of how that is contributing. And then there's thinking, okay, if we have improved systolic and diastolic function, maybe this shows how we can have less pulmonary congestion, less hospitalizations for heart failure, less arrhythmias potentially. And then all of this could trickle down and improve renal outcomes too, because we know these disease states are intimately related. So right now, this is kind of the thought process behind this class of medications and why we think they work really well. And all the ones coming up. So these will be exciting, especially for you guys. So we have dapagliflozin will have its heart failure study specifically, its CKD study specifically. Empagliflozin is doing preserved and reduced ejection fraction studies. The canagliflozin credence study, it's been finished but not published. This was a renal outcome study that was actually stopped early because they met that pre-specified endpoint. So they do appear to have been a benefit in decreasing those renal outcomes when that's their primary outcome. So that'll be coming out, which will be exciting. And then ortugoloflosin has to do their study, again, because they're new to the market. And so I imagine it'll kind of learn from all these other ones and be similar to the ones we've reviewed. Okay, and I know that was a ton, but it's because we kind of had to review the old guys. Next time, the plan is really to talk about the GLP-1 receptor agonist. Those are our other class of medications that we keep